Right, so starting with the ECG, we'll have a look at the most important points, the images and some drugs management. So normal ECG, basically lead 1, lead 2 and lead 3. First question, what limb is used as a ground electrode basically in while we are taking ECG? Right foot. Remember, it's the right foot. So it is always right, it is always good to stay grounded. Right foot, right on the ground. So right foot on the ground. So remember in the leads, basically this triangle, you have the right arm, the left arm, and you have the left lower limb. You do not have the right foot. So this is the direction of lead 1, then you have lead 2 and you have the lead 3. For assessment of rhythm, we take a long lead 2, right? A long lead 2 is for assessment of rhythm. So in the ECG, what does the P wave indicate? Atrial depolarization. QRS is the ventricular depolarization, and then is the T which indicates the ventricular repolarization. Right, so basically it is the atrial depolarization, ventricular depolarization and ventricular repolarization. What is the difference between the PR interval and the PR segment? PR segment, anywhere in ECG, segment basically means a flat line. It's an isoelectric line. It's a flat line. Interval means it contains at least one wave. So remember that PR segment is a flat line between where the P ends and where the QRS begins. It's a flat line. It has no wave. Interval, the PR interval is calculated from the beginning of P to the beginning of QRS, end of QRS. Beginning of QRS. So remember that PR interval is from beginning to beginning. Beginning of P to beginning of QRS. The QT interval on the other hand is, remember QT interval is for both the ventricular depolarization plus the ventricular repolarization. That means it is from the beginning of QRS to end of T. It is not beginning to beginning. It is beginning of QRS to the end of the T. That is what is QT. And this is your ST segment, right? Again, which is a flat line. End of QRS to beginning of T. That is ST segment. This is PR segment. So the PR interval we have already seen is from the beginning of P to the beginning of QRS. Normal is how much PR? 0.12 to 0.20. That's basically how many small squares? 3 to 5. Because one small square is what duration? 0.04. So when I say it is 0.12, it is 3 small squares. 0.20 is 5 small squares. So if you look at the ECG, the one big square has 5 small squares. So that will be how many seconds? 0.04 into 5, that is 0.2 seconds. So I can say that PR interval is basically one big square. The normal is, upper limit is one big square. QT interval is from the beginning of QRS to the end of T wave and the normal is 0.44. What is the Bazet's formula for corrected QT interval? And what is the corrected QT interval? It is QT divided by square root of RR interval. QT upon under root of RR, that is the Besset's formula for corrected QT. PR segment is the flat line, end of P to beginning of QRS. Segment basically means isoelectric. So PR interval beginning to beginning, QT interval beginning to end. Now in the ECG, the axis deviation, what leads to be used to determine the axis in the ECG? The lead 1 and the lead AVF. Right, 1 AVF या 1 and 2 भी कर सकते हैं. 1 AVF या 1 and 2. Normal axis is where should be the lead 1 and the lead AVF. So if you have a look at the ECG, you look at the lead 1 and you look at the lead AVF. Normal matlab both are upgoing. Normal axis is both upgoing, that is both positive. So remember that normal, what is normal? Being positive everywhere, that is normal. Okay, so normal is positive everywhere. So lead 1 also more positive and AVF also positive. Left axis deviation, right axis deviation. Left axis deviation basically means it is leaving each other. So if you look at the lead 1 and the lead AVF, the positive, the predominant component here is positive, this is negative. That means 1 is going up, AVF is going down. That means they both are leaving each other. They are going in the opposite direction. Right axis deviation means R for R reaching towards each other. So left axis is leaving, right axis is reaching towards each other. That means both of them are coming towards each other. 1 negative, AVF positive. And what is the extreme axis? Extreme is both negative. Right, so normal is both positive. If it is all negative, both negative, it is extreme. So if you look at the quadrant here, if this is normal, diagonally opposite of that is the extreme axis. So remember that this is where like the heart is. So this is normal, this is extreme. So extreme को मतलब कौन सा direction बोल सकते हैं? What direction is this? North. कौन सा direction? North western. Okay, so this is extreme axis is north west axis. Okay, this is the northwest. That is extreme. So normal is like this. Okay, this यहाँ पे जो है, this is the normal. So what is the normal axis? Between what values? Minus 32 plus 90. Remember that नीचे जो है ये है plus 90, जो ऊपर है ये minus 90. ऐसा नहीं है यहाँ कि जो ऊपर है वो plus है. It is उल्टा. नीचे वाला plus 90 and ऊपर वाला is minus. So the normal axis is minus 30 to plus 90. Lead 1 and AVF you check for, both positive is normal. Left axis deviation means if this is the heart here going more towards the left side, that means it is becoming more negative. So minus 30 to minus 90. Left axis is leaving each other, so positive and negative. Right axis means this is where the heart is going towards the right side. Okay, that's the right side. So plus 90 to 180 and northwest is basically this area which is minus 90 to plus 180. If you remember this diagram, you remember the values. So upper wala is minus, this is plus, minus 30 to plus 90 is normal. So it's minus 30 to plus 90. At least remember the normal axis is minus 30 to plus 90. Now, if the patient has right ventricular hypertrophy, it will cause what axis deviation? अगर right ventricle hypertrophy हो रहा है, so remember this is right, this is left. If the right ventricle is getting hypertrophied, so imagine that the right side is getting dominant. So where is the heart shifting? It is the right axis deviation. So remember that LVH will be left axis deviation, RVH will be right axis deviation. So जहां hypertrophy हो रहा है, that side is the deviation. So LVH is left, RVH is right. Hemifascicular block, left anterior, left posterior, which is what axis deviation? So left anterior, that is LA. Remember, like in Villa, LA is the left axis deviation. Remember Ralph? Ralph basically helps you to remember that right axis deviation is with LPH, left posterior hemiblock. So left posterior hemiblock is Ralph. It is right axis deviation. If a patient has right pneumothorax, how will be the axis deviation? Right pneumothorax is left axis deviation or right axis deviation? अगर right pneumothorax है तो mediastinal shift कहाँ होगा? Left side. So the heart is also going to the left side. So how is the deviation? Left. So remember that left pneumothorax will cause right axis deviation. Right pneumothorax will cause left axis deviation. This is asked frequently in the exam, right? So don't make a mistake here. Right pneumothorax, left axis, left pneumothorax, right axis. Right, so if they give you an ECG and they ask you that this ECG is seen in all of the following conditions except, so basically axis deviation अगर आपको देखना है, so left axis you'll identify by 1 and EF leaving each other, right axis is reaching towards each other. So right axis is Ralph, it is RVH and LPH, the left posterior hemiblock and the left pneumothorax. Okay. Next one, electrolyte abnormalities, potassium and calcium, hypokalemia, hyperkalemia, hypocalcemia and hypercalcemia. So talking about potassium first. Potassium basically is responsible for what in the action potential? Repolarization. Right, so remember here also it is ventricular repolarization. What wave indicates ventricular repolarization? T wave. So whenever the potassium changes, you will see the effect on the T wave first. So decrease potassium, decrease T wave. Increase potassium, increase T wave. So potassium basically is T wave. Hypokalemia, the T wave will go down. Hyperkalemia, what is the first ECG finding in hyperkalemia? Tall tented T waves, right? So increase the potassium is increase the T wave. Remember the effect on the P wave is opposite. Opposite with the P wave. If the T decreases, what happens to the P? Increases. If the T increases, what happens to the P? Decreases. So if it is tall tented T wave here, what is happening to the P wave? Flat. Increase T is decrease P. In hyperkalemia, in severe hyperkalemia, more than 8.5, more than 9 milliequivalents, you talk about what pattern? Sine wave pattern. So remember sine wave pattern, if you get confused, it's increased or decreased potassium. Sine wave, IN is increased potassium, severe increased potassium. Sin is severe increased potassium. So the sine wave is basically like this sine, the wave, and that basically indicates your very broad QRS. So you see the widened QRS, when significantly widened, it leads to sine wave pattern. In hypokalemia, what is happening to the P wave? Hypokalemia. So start thinking like potassium कम हुआ, P कम हुआ, तो P क्या हो रहा है? Increase. So what is a tall P wave called as? P. What is the term? P pulmonale. It's a peak to P wave. So this is called as pseudo P pulmonale because it's not a hard car condition, right? It's not actually the right atrium enlargement. So where do you see pseudo P pulmonale? Which electrolyte abnormality? Hypokalemia. Peak to P wave. Shallow T wave. What else do you see in hypokalemia? U wave. Remember, U is UK, that is underkalemia. U wave is seen in UK, that is underkalemia, that is hypokalemia. Has been asked in one of the recent NEET PG exam also. U is UK underkalemia. Right, so if this is the ECG here, after the QRS, remember that you have the shallow T wave and you have a prominent U wave is hypokalemia. The P wave becomes more prominent, the T goes down. In your hyperkalemia, it is a tall tented T wave. The T wave increases, the P wave goes down. Prolonged PR interval can be seen in both. Hypo, hyper both will be prolonged PR interval. Okay? Next one, that is about calcium. So when the calcium increases, what is calcium required for? Heart contraction basically. So if the calcium is more, everything becomes fast. So what will happen to the duration? It will decrease or it will increase? Decrease. So the QT decreases. Calcium is QT. The ventricle repolarization, pura, that's the entire ventricle. So increased calcium is decreased QT. Hypocalcemia is QT prolonged. And we have seen that prolonged QT interval increases the risk of Torsades pointers, where the drug of choice is magnesium sulfate. Torsades pointers, also called as polymorphic ventricular tachycardia. The causes are all the hypokalemia, hypocalcemia, hypomagnesemia. If they ask what's the most common actually is hypokalemia. So all the hypos is Torsades pointers. U wave, UK, it is seen in underkalemia. Remember, hypokalemia. With digoxin, what are the ECG findings with digoxin? What are the various ECG findings with digoxin? On the PR, on the QT, and on the ST. PR is prolonged. So remember that digoxin, PR is PR, prolonged. QT is shortened. QT is choti, that is decreased. ST is depression, elevation. ST is depressed. Depressed ST. QT, choti. PR, prolonged. Right? So remember the rhyming words here for digoxin. Whenever I say the PR is prolonged, that basically is suggestive of AV block. Right? So basically it's a marker of AV block. Did we see digoxin causes AV block? Yes, that's why it is used for rate control in atrial fibrillation. PR prolonged. Why does it cause QT shortening? Increase in calcium. Did we see digoxin increases calcium? Yes, by inhibiting sodium potassium ATPase. And there is ST depression. What sign is that called as? The ST depression. ST depression. The reverse tick mark or the hockey stick sign. Okay, hockey stick or the reverse tick mark is digoxin. ST depression. Right, so this ECG basically is showing the prominent U wave under calemia. This ECG is showing that, the increasing and the decreasing pattern. This is for torsidis D pointus. Okay, a ribbon which is twisted. So increasing and decreasing. What is the treatment of hyperkalemia? Hyperkalemia, if the ECG changes are present, first thing is stabilize the heart, and for that you will give IV calcium gluconate. Remember, IV calcium gluconate does not decrease the potassium levels. It is just stabilizing the heart. To decrease the potassium levels, we will give insulin, because insulin will cause hypoglycemia. So you will give it dextrose. Remember, insulin takes the potassium in. Takes potassium in is insulin. So it decreases the potassium levels. It takes the potassium in. Salbutamol. What is the side effect with salbutamol? Hypo. It is taking the potassium in. So it will cause hypokalemia. Right? Remember, salbutamol causes hypokalemia and hyperglycemia. So similar to insulin, even the salbutamol, the beta stimulation leads to the inward movement of potassium. Caxylate, that's basically the potassium binding resin, and diuretics, which cause increased potassium loss in the urine. All these will decrease the potassium levels. Calcium gluconate does not decrease the potassium levels. It is just stabilizing the heart. ECG in supraventricular arrhythmias, that is PSVT, atrial fibrillation, atrial flutter, and MAT, multifocal atrial tachycardia. The first one is PSVT. Right, paroxysmal supraventricular tachycardia. When I say it is tachycardia, that means the heart rate is increased. That means the RR interval is decreased. Why this is PSVT? Why this is not atrial fibrillation? Look at the rhythm. The RR interval is constant. Okay, it's not changing. It is a regular rhythm. So there's a regular RR interval, there is regular rhythm. So that's why this is not atrial fibrillation. And you will see the P wave being absent. Because the P wave gets combined into the QRS, it is hidden there. So here also the P wave is absent, similar to atrial fibrillation, but the rhythm is regular. How do you manage a patient of PSVT? Depends on whether the patient is stable or unstable. Unstable patient, that is systolic blood pressure less than 90, first thing you have to do is cardioversion. Right? You will not waste time. Directly you would do a cardioversion. Stable patient, systolic BP more, you have time. So what do? The supraventricular tachycardia, you don't want that to be transmitted. So you will block the AV. So what is the treatment target here? Basically doing the AV block. How can I do the AV block? Sympathetic, parasympathetic? Parasympathetic. So what will we do is vagal stimulation, which stimulates the parasympathetic system, stops the AV conduction. Right? And how can I stimulate the vagal is basically by carotid massage. Always unilateral, never bilateral. We will not do bilateral carotid massage. It's a unilateral carotid massage. We can use ice pack. If this does not work, next is coming to drugs. What is the drug of choice? Adenosine. Always IV. The drug of choice is IV adenosine. The dose is 6 milligrams. Adenosine is class 5 antiarrhythmic. Remember, this is an antiarrhythmic drug which can cause bronchospasm and flushing. So in the asthma curve diagram, where we had, the substances causing bronchodilation, causing bronchoconstriction. Bronchoconstriction is acetylcholine, leukotrienes, and also the adenosine. Remember, adenosine causes bronchospasm and flushing. Right? Important question. If it is not responding to adenosine also, then the next drug is calcium channel blocker and beta blocker. These are also the drugs which cause the AV block. Remember ABCD, beta blocker, calcium channel blocker. This is atrial fibrillation, where you see that the baseline is not constant and even the rhythm is irregular. यहाँ पे RR इतना है, यहाँ पे RR कम है, फिर RR ज़्यादा है. It is irregular RR interval with the P wave absent. And generally this is seen in alcoholics, right? Alcohol, binge alcohol, holiday heart syndrome. On a holiday, binge alcoholic, holiday heart syndrome is atrial fibrillation. The focus here of origin in atrial fibrillation is the left atrium, where the pulmonary vein is opening. So in atrial fibrillation, the treatment is rhythm control, rate control, and we also look at anticoagulation. So for rhythm control, we have ibutilide, which is what class antiarrhythmic? Class 3, AIDS. Propafenone, 1, class 1. And amiodarone, class 3. So for rhythm control, you have ibutilide. It is propafenone and amiodarone. For rate control, basically what will you do for rate control? AV block. B, C, D. A, B, C, D, beta blockers, calcium channel blockers, digoxin. We have said that you should never give CCB and beta blockers together because significant bradycardia by the AV block. Why do you want to give anticoagulation in a patient of atrial fibrillation? Right, because अगर atrial fibrillation contract नहीं हो रहा है atrium, blood stagnating, forming a clot, so there can be a LA clot formation, left atrium clot, which can embolize and lead to stroke. Right, so atrial fibrillation clot बन के फिर embolize होके stroke हो सकता है. So to visualize this clot in the left atrium, what investigation will you do? Transesophageal, not transthoracic. Better is transesophageal. Why? Since the left atrium is posterior most chamber of the heart. If you see from the front, transthoracic, it is behind. It is posterior. You go through the esophagus, the left atrium is close to esophagus. It is posterior most, but it is close to esophagus. So anticoagulation is given based on calculating the score, the Charles-Vask score. It is used to determine the need of anticoagulation. What is the drug of choice for anticoagulation now? NOACs. What are the NOACs? Dabigatran and rivaroxaban, the 10A inhibitors. Dabigatran is a direct thrombin inhibitor which is given oral. One of the last to last year EPJ exam question. Instead of NOAC, we prefer giving warfarin. In what cases? If it is mitral stenosis, that is rheumatic heart disease, or it's a prosthetic valve. So if that is related, the patient has mitral stenosis or a prosthetic valve, so we will give warfarin. So remember that warfarin is related to the valve, either stenosis or either prosthetic. Okay, warfarin, if it's a valvular, something related to the valve. What do you monitor with warfarin? PT, right? Extrinsic pathway wet, warfarin is PT monitored. PT-INR. Atrial flutter is identified by these sawtooth waves. Right, the sawtooth waves, it is more regular rhythm as compared to atrial fibrillation, but it has this classical sawtooth waves, and the management is similar to atrial fibrillation, just that in atrial flutter, the origin here is right atrium. In atrial fibrillation, it is the left atrium. So left atrium and the LA clot is in atrial fibrillation. In multifocal atrial tachycardia, the classical history would be a patient of COPD. Right? If you have a history of COPD with the ECG given, think of MAT. Multifocal atrial tachycardia, that means the tachycardia is coming from the atrium. So which wave will be affected? P wave. Multifocal, matlab it's coming different foci se. So it is going to be multimorphic. Polymorphic, matlab the P wave that you see, minimum 3 different P waves is what you would see. So multimorphic P waves more than 3. Remember, you do not give cardioversion here in MAT. We give calcium channel block. How do you differentiate in ECG whether it's a supraventricular tachycardia or it's a ventricular tachycardia? Depending on the QRS. When we say it's a ventricular tachycardia, that means from where is it coming, the tachycardia? Ventricle. That means it is abnormal pathway of the heart activation. Normal pathway is SA node, AV node, then the ventricle. If it is ventricle, that means it's an abnormal pathway. Whenever you have the heart, the ventricle getting activated by abnormal pathway, it always gives a broad QRS. Okay, remember this point. Whenever it is abnormal pathway, not the normal pathway, the QRS is broad. So ventricular tachycardia, bundle branch block. If a bundle branch is blocked, that means the ventricle will not receive the signal from the normal bundle branch, but some other pathway. So that is also going to give you broad QRS. Right, so remember bundle branch block, ventricular tachycardia is broad QRS. Supraventricular, that's basically the normal pathway, is a narrow QRS. Right, so this is something which is the summary. We have discussed this, the points that are given here. The image review basically here. The baseline is not flat, not stable. The RR interval is changing. This is atrial fibrillation, right? In MAT, you would see the P waves, which are of different morphologies, at least 3 waves. Fibrillation is relatively regular with this sawtooth pattern, right? And which is looking like a normal one, just that there is tachycardia and you are not seeing the P wave. This is going to be PSVT. Okay, the RR interval, the RR is close, the P wave is absent. Okay, that is PSVT. Coming to Wolff-Parkinson-White syndrome, basically what's the pathology in Wolff-Parkinson-White is the accessory pathway, that's a bundle of Kent. It's an abnormal pathway. So how will be the QRS? Any abnormal pathway? Broad QRS. So here also you would see a broad QRS. How will be the PR interval? Short. Why? Because the accessory pathway, the bundle of Kent is faster conducting. Right? The bundle of Kent is faster conducting. So PR interval will decrease. The QRS shows the delta wave. So remember the findings in WPW is delta waves, short PR and a broad QRS. So in WPW, basically if there is an AV node and there is a bundle of Kent. The bundle of Kent is trying to take the signal to the ventricle, abnormal pathway, broad QRS, faster conducting PR short. So in WPW, should you give AV blocking drugs or should you not give AV blocking drugs? Dena chahiye ki nahi dena chahiye? Nahi dena chahiye, because both of these are competing, right? So basically to conduct the signal, now there are 2 competitors, AV node and the bundle of Kent. If you will block the AV, who will win? The bundle of Kent. So do not give the AV blocking drugs in WPW syndrome. So remember, avoid AV blocking drugs, which are B, C, D. Beta blocker, calcium channel blocker, digoxin नहीं दोगे. What is the definitive treatment? Ablation, right? Kill this bundle of Kent. Radio frequency ablation of bundle of Kent. That's the definitive treatment. So it will go forever. So delta wave is basically this upsloping. Normally the QRS goes up very sharp. When it's a slow rising QRS like this, that is called as delta wave, seen in WPW. The PR interval is going to be short, less than 120. The QRS is basically broad. So broad QRS, short PR, and there's a delta wave. What drug do you give in WPW? Procanamide. Avoid the AV nodal blocking drugs. So that was about supraventricular, where we have learned about atrial fibrillation, PSVT, flutter, MAT, and WPW syndrome. Okay? Coming to ventricular arrhythmias will be broad QRS or short QRS. Broad ki short. Broad because it is abnormal pathway. So QRS broad ventricular tachycardia can be monomorphic, can be polymorphic. Monomorphic मतलब सिर्फ एक ही morphology का ऐसा दिखेगा ECG with the broad QRS. That is monomorphic. And what do you see in polymorphic? Torsitis G point is increasing, decreasing. ठीक है, ऐसा वाला दिखेगा in torsitis G point is. So if you look at the ECG here, especially in the ECG, always try to look at the lower one. If you are given a long lead 2, that's a hint that you have to look at some arrhythmia here. A long lead 2 showing this pattern, which is monomorphic with the broad QRS. Basically, this is ventricular tachycardia. And for ventricular tachycardia, the drug of choice is amiodarone. Okay, it's amiodarone. The treatment is cardioversion, basically to prevent its conversion to ventricular fibrillation. Right? You don't want VTAC to convert into VFib. So cardioversion is the treatment of choice. If the drug of choice is asked, it is amiodarone. We have already seen that amiodarone is a broad spectrum antiarrhythmic used in all except torsitis G pointus and digoxin induced because it increases the digoxin toxicity. What are we seeing here? Right, this is just the ventricular fibrillation, like you have atrial fibrillation where you would see the absent P wave irregular rhythm. Ventricular fibrillation, the amplitude will be less. Fibrillation matlab contraction kam hai. So ventricular fibrillation will just have these short waves. There is no regular rhythm there as well. So remember, small amplitude waves, the treatment here is defibrillation. Fibrillation mein, you'll have to do defibrillation. And this one, where you see a flat line, basically this is a asystole, right? Asystole, there's no activity, it will be flat. And what is pulseless electrical activity? Correct. Pulseless, that means there is no pulse. But if you see the ECG, that is almost like normal. So ECG normal with no pulse is pulseless electrical activity. What will be the treatment there? Is it shockable rhythm? No, it is not shockable. So the drug of choice here is epinephrine. Right, the electrical activity is there, the mechanical is not there, the pulse is not felt. So you give epinephrine like you give in cardiac arrest basically. The pulseless electrical activity, we will give epinephrine. This is the torsitis depointus, where you would see a pattern like this. Okay, a pattern like this is torsitis depointus. The drug of choice is magnesium sulfate. It is associated with QT prolongation. What class of antiarrhythmics is this? QT prolongation? Class 3 and class 1A. Right, so wide complex tachycardia, that is wide QRS complex, which is more than 120. You will have VTAC, torsitis depointus, ventricular fibrillation. In VTAC, you have this monomorphic basically pattern which is there, right? All these fusion beats, capture beats are the terminologies which are seen in VTAC. Fusion beat, capture beat is VTAC. Ventricular fibrillation, defibrillation needs to be done. ECG in AV block. Whenever the AV will be blocked, what is the finding that you would see on ECG? PR prolonged. AV अगर block होगा तो P को ventricle के पास जाने के लिए time लगेगा. So that is why the PR will prolong. So first degree, second degree and the third degree heart block. In first degree heart block, what will you see is just the increased PR interval. There is no dropped beat. While a second degree heart block is identified by second matlab do and it has a dropped beat present. In second degree heart block, you will see a dropped beat present. So in second degree, you have Mobitz type 1, Mobitz type 2, which is the Wenckebach's phenomenon. 1. Remember, 1 is Wenckebach's. Wenckebach's phenomenon is 1. What is the Wenckebach's phenomenon? The PR interval keeps on increasing, and finally you see a dropped beat. So there is progressive increase in PR, then there's a drop in the beat. While in Mobitz type 2, it's not a progressive increase, it's a constant PR interval increased. So what is the difference between a Mobitz type 2 and a first degree heart block? दोनों में constant increase है. Dropped beat, right? That's what you have to check for. In Mobitz type 2, it's a constant PR interval with a dropped beat present. In first degree, there is no drop beat. Right, so if you look at the ECG here, this is showing the PR. We said that more than 1 large square, 5 small squares, it's a prolonged PR. Definitely this is more than 1. PR is constant here. And are you seeing any drop in the beat? Every P is followed by a QRS. Is there a drop? No. So that's why this becomes your first degree heart block. Okay, this is first degree. Next one, second degree heart block. If you look at this one, what is happening to the PR interval? Look at the PR interval. Is it constant? No, the PR interval is progressively increasing, right? It is progressively increasing. And then you see that there's a drop. So that is why this is second degree heart block, Mobitz type 1, Wenckebach phenomenon. So even in your Mobitz type 1, no treatment is generally required. While in Mobitz type 2, you require a pacemaker. If you see a dropped beat, it is second degree. Then look at the PR interval. If it is constant, it's a Mobitz type 2. And what happens in your third degree heart block? Third degree heart block is like a complete heart block. So what happens is, ये पूरा block हो चुका है. Atrium अपना contract कर रहा है, ventricle अपना contract कर रहा है. So the PP interval is constant, the RR interval is constant, right? The RR interval will be constant in third degree heart block. So remember, the third degree heart block, atria and ventricles are independent. The PP interval, the RR interval is regular. but they are independent of each other. कभी भी P wave आएगा, P wave QRS के ऊपर आएगा, P wave T के ऊपर आएगा, कहीं भी आ सकता है, because atrium is now not dependent on the ventricle, or ventricle is not dependent. Okay. And one condition that you should remember which can cause this third degree heart block is Lyme's disease. What is Lyme's disease caused by? Borrelia burgdorferi. Right, Borrelia burgdorferi. Bundle branch block, did we see what QRS does it have? Narrow or broad? Bundle branch block हो गया, pathway block हो गया, तो abnormal pathway आएगा तो क्या होगा? Broad QRS. There will be broad QRS. So right bundle branch block, left bundle branch block. Remember, for the right it is marrow and for the left it is bilium. LL is left, RR is right. So what do you see is, this is M pattern in V1, W pattern in V6, W pattern in V1, M pattern in V6. So in right bundle branch block, if you see the V1 lead, you are going to see this M pattern. Okay, the M pattern of the R wave. So remember, marrow helps you to remember is right bundle branch, bilium is left bundle branch. Right, so looking at the images here, is it the first degree? Is it second degree? Is it third degree? What is it? It is not first degree. Why? Because we see a drop beat. QRS है, QRS है, QRS है, but QRS नहीं है. There's a drop beat. So I know it's a second degree. Then we will look at the PR interval, progressively increasing. So what is it? Mobitz type 1, right? This is Mobitz type 1, Wenke back, second degree heart block. Okay? Next one, if you see here, again there's a drop beat here. So it's a second degree. Look at the PR, constant. So what is it? It is Mobitz type 2. Constant PR with a drop beat. This is Mobitz type 2. If you are given an ECG like this and you are asked, is it 2:1, 3:1, 4:1, what heart block is this? Why is it 2:1? It's already written. Why is it 2:1? 2:1 मतलब when you are seeing a drop, उसके पहले ये P waves कितने हैं? 2. This is 1P. This is second P. QRS कितना है? 1. So for 2 P waves, there is 1 QRS complex. Okay, so that's why this is your 2:1 block. 2P and 1 QRS. That is how you calculate the 2:1 or 3:1. So 2 P waves, 1 QRS complex. In third degree heart block, the most important point I want you to remember is, how is the RR interval? Constant. The RR is constant, it is not irregular. The PP is constant, the RR is constant. But P can overlap R, P can overlap T. They are independent of each other. That's what you need to know. Coming to ECG in MI and pericarditis, why are we discussing MI and pericarditis together? Because both of them show ST elevation. The difference is, in MI, remember MI is a sad event. So it is sad. MI is sad. So how is the ST elevation? Like a sad face, it is convex upwards. Pericarditis is a smiling. So how is the ST elevation? Concave upwards. Which refractive error you use a convex lens? Hyper. Convex matlab going up. Hypermetropia. Myopia is concave minus. Okay, concave minus. This is convex upwards. So this is how you would see the ST elevation in MI, and here you would see the ST elevation which is concave upwards. Okay, pericarditis and MI. The other difference is MI is the infarct, and infarct is basically vessel block. So it is vascular territory limited. MI में ऐसा नहीं होगा कि कोई भी random leads में you would see ST elevation. It is limited in the vascular territory. While pericarditis, when the pericardium is inflamed, उसके अंदर है myocardium. The entire myocardium is getting affected, and that is why the ST elevation is diffuse. सब leads में दिखेगा. Except which lead can show the depression? AVR. Right? AVR उल्टा जाता है. Remember reverse in AVR. So along with ST elevation in pericarditis, you have the PR depression. ST elevation, PR depression. So that's the difference between pericarditis and MI. How do you localize the MI? Is depending on what leads are showing the ST elevation. So remember that in your left ventricle, basically septal, anterior and lateral. That's how it is going from midline to lateral jaw. So septal, anterior and lateral. With the septal MI, septal wall, तो फिर उसमें कौन सा lead में आएगा? How do you keep the ECG leads? Basically, if you see here, ECG leads ऐसे जा रही है. It is V1, V2, V3, V4, V5, V6. So if the ST elevation is in V1, V2, it is what MI? Septal. V3, V4 is anterior. V5, V6 is lateral. So V1, V2, V3, V4, V5, V6. If it is septal or anterior, what are the branches of the left coronary artery? It gives one anterior descending branch and it gives one circumflex, right? So what is going on the lateral side of the heart from the LCA is the LCX, circumflex. The rest of the two is LAD. Septal anterior LAD, lateral is LCX. The leads beyond V6, right? अभी आप scapula के ऊपर अगर leads रख रहे हो, तो V7, V8, V9, this is पीछे. These will be what MI? Posterior. Right? So posterior is V7 to V9. अगर posterior leads नहीं रख रहे हो, you would see the reciprocal changes in the anterior leads. That means lead V1 to V3 will show ST depression, reciprocal changes. तो posterior में MI हुआ तो आगे वाला depression दिखाएगा. So depression in V1, V3 with tall R waves is what you will see here. So V1, V2 septal, V3, V4 anterior, V5, V6 lateral. If it is AVL, right? If it is lead, your 1 and AVL, this is what am I? Just lateral. Remember that V5, V6 is like enterolateral, and if it is just asking about lateral, so it is the lead AVL. Right? Be it enterolateral, be it lateral. You have the circumflex there. And if it is the lead AVF, F stands for foot. Where is the foot? Inferior. So AVF is inferior wall MI, AVL is lateral wall MI. So in inferior wall, what leads show the ST elevation? 2, 3 and AVF. Remember, inferior is the feet. We have 2 feet and this is feet wala AVF. 2, 3 AVF. What artery is inferior wall MI generally? RCA, right coronary. In the ECG, where do you localize the leads is? Remember, ये जो ऐसे boot shape दिख रहा है, foot shape, boot shape, तो ये कौन सा वाला होगा? Foot shape का जो दिख रहा है, inferior. Okay, so that is lead 2, lead 3, and this is where you have lead AVF, 2, 3 AVF. So in the ECG, if you are seeing in this area, basically this is 2, 3 AVF. The lateral one is your lateral edges in the ECG. That means it is lead 1. You have the lead V5, V6 और यहाँ पे आता है AVL. So So look at the ECG here again. Basically, what is foot shape here is the inferior wall, lead 2, 3 AVF. The lateral aspect, the lateral wall along with the AVL. This is V1, V2 septal, V3, V4 anterior. Okay, that's where you have to see the ST elevation. So looking at this ECG, what are we seeing here? Where is the ST elevation? Where is the ST elevation? It seems to be an extensive MI where you are seeing the ST elevation. Are you seeing here in 2, 3 AVF? यहाँ पे दिख रहा है? Right? So inferior wall है. What are you seeing in V1 and V2? What is this in V1 and V2? ST depression. ST depression in V1, V2, basically you will think of posterior wall MI. Okay? 2, 3 AVF affected. This is inferior wall MI. Remember that inferior and posterior generally go together because both of them is what artery? Right coronary artery. And this inferior wall MI presents with bradycardia. Important. Why? Correct. Because right coronary artery supplies the SA node, AV node. So when the right coronary artery is gone, SA node, AV node gone, there will be bradycardia, there will be hypotension. So remember that here in the treatment of inferior wall MI, you will give atropine to overcome that bradycardia and IV fluids. IV fluids and atropine. So inferior wall is 2, 3 AVF, it is right coronary artery. This is showing the lead V2, which is showing this ST elevation depression. Depression. So ST depression in V2 with a dominant R wave. This is reciprocal change of posterior wall MI. This one is MI or pericarditis. The ST elevation concave upwards along with what are you seeing here? PR depression. ST elevation with PR depression concave upwards. This is pericarditis. Okay, this is pericarditis. MI ECG changes. If they ask you what is the first change? T waves. First to be affected is the T waves. The tall T waves. First comes the T. Then comes this ST elevation, which is convex upwards. This is called as Pardy sign or the tombstone appearance. You know how the tombstone is convex upwards. And old MI is indicated by Q waves. Prominent Q wave is the old MI. Q is old MI. So Q wave with T wave inversion is what you see in old MI. So remember that the first change is the tall T waves and not the ST elevation. Right, so that was the overview of ECG where we have discussed your the electrolyte abnormalities, the AV block, the arrhythmias, the MI and pericarditis. Remember few waves. One wave is the Osborn wave. Osborn wave is seen in hypo. Osborn. OO. It is seen in hypothermia. Right, at the J point where the QRS is ending, there would be a wave, hypothermia. Osborn wave is hypothermia. Epsilon wave is? It is epsilon wave is ARVD. Arrhythmogenic, right ventricular dysplasia. Right, so basically in ARVD, what happens is, why is the right ventricle becoming arrhythmogenic? Because the muscle of the right ventricle has been replaced by fat, fibrofatty tissue. So if they tell you that the muscle has been replaced by fibrofatty, what will you see in the ECG? It's the epsilon wave. Delta wave we have already seen. Delta, WPW, Wolf Parkinson White, Osborn and epsilon. Right, so that's about ECG. Coming to JVP. So JVP is something that you need to know first. The normal JVP में क्या क्या indicate करता है, and then what are the various pathologies that we see in the JVP. So this we will do along with the physiology part. ठीक है? So we'll come to acid base. Right? Very very important. At the same time has a lot of tricks to remember the stuff. Right? So I remember giving the NEET PG 21 exam. That was the time when your pattern changed from 300 questions. Now you have 200 questions, right? So to experience that, I gave the exam myself, and that exam, I remember that had 4 to 5 questions on acid base. अगर acid base छोड़ के गए और 4-5 क्वेश्चन एक ही एग्जाम में आ गए, you can imagine how your rank is going to get affected. Even one question here and there, especially in the mid-rank segment, it makes a lot of difference, right? So acid base disorder is a topic which you have to do very very well, and all the questions were based on identifying the disorder. None of them was on ki compensation calculate karo, right? They don't ask you in a lot of details, but the concepts, basic concepts are definitely tested, right? So in acid base disorders, metabolic and respiratory disorders. So the most important mnemonic that you should never forget here is ROME. Right, that's the most important trick. ROME stands for respiratory opposite, metabolic equal, or metabolic same. ME in metabolic equal or metabolic same. What are we talking about this opposite and same? The change in the pH versus the change of the other two substances, that is PCO2 and bicarbonate. Remember that this PCO2 and bicarbonate, they go together. Right? They go together. In compensated disorders, they go together. So if the bicarbonate is decreasing, as the compensation, what happens is PCO2 also decreases. If the bicarbonate is increasing, the compensation is increase in CO2. So remember that both of them go together. One decreases, other decreases. The change in the pH is what we are talking about, whether it is opposite or whether it is same. So if you look at the table here, PCO2 bicarbonate, decrease, decrease, increase, 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 decrease. Both of them are going together, right? They are same. Now, if the PCO2 is decreased and your pH is also decreased, both of these are decreased and pH is also decreased. How is the change? All the three are same direction, equal, right? Going in the same direction. So this is what disorder? Metabolic or respiratory? Metabolic. Metabolic same, metabolic equal. Why do I call it acidosis? Because how's the pH? Decreased. So whenever you are asked to identify whether what disorder it is, first thing look at the pH. अगर pH कम है तो acidosis, pH बड़ा है तो alkalosis. Next देखो कि respiratory है कि metabolic है. How will you decide that is? If the pH is decreased, the rest of the two are decreased, it's metabolic. pH is decreased, the rest of the two are increased. It is what change? Opposite. So this is respiratory. Right? So basically remember, in metabolic equal or same means all three decrease or all three increase. All the three go in the same direction. pH, PCO2, bicarbonate. And to remember that, हम कब बोलेंगे कि decrease है कि increase है, you should know the normal values. What is the normal value of pH? Remember all four containing values. 7.4. PCO2 is 40, and bicarbonate starts with bi, that is 2, and it has a 4, 24. Do not get confused कि bicarbonate 24 था कि PCO2 24 था. Bicarbonate starts with a bi, that's a 2. So 2 and 4, 24 is bicarbonate. Now next one, hyperventilation will lead to what acid-base disorder? सबसे पहली बात, रेस्पिरेटरी होगा कि मेटाबॉलिक होगा? रेस्पिरेटरी. वेंटिलेशन का प्रॉब्लम मतलब रेस्पिरेटरी प्रॉब्लम, so it is respiratory. Alkalosis की acidosis? Alkalosis. Why? CO2 वॉश आउट ज्यादा होगा, PCO2 कम होगा. रेस्पिरेटरी है तो pH कैसा होगा? बढ़ेगा, ऑपोजिट. So this is alkalosis. Right? Opposite, hyperventilation is a compensatory mechanism in which disorder? When it's a metabolic problem, the lungs compensate. When it's a respiratory problem, the kidney compensates, right? The rest of the metabolism compensates. So if we are saying that hyperventilation is a compensation, so it's a what disorder we are talking about? Metabolic. Acidosis की alkalosis. कौन से एसिड बेस डिसऑर्डर में हाइपरवेंटिलेशन कंपेंसेशन होगा? मेटाबॉलिक एसिडोसिस. रिमेंबर डायबिटिक कीटोएसिडोसिस इज व्हाट टाइप ऑफ एसिडोसिस? मेटाबॉलिक है कि रेस्पिरेटरी है? लंग का कोई प्रॉब्लम है? नहीं, ये मेटाबॉलिज्म प्रॉब्लम है. सो दिस इज मेटाबॉलिक एसिडोसिस. उसमें क्या दिखता है? स्मॉल ब्रीदिंग दिखता है, व्हिच इज हाइपरवेंटिलेशन, राइट? सो रिमेंबर दैट इन DKA we see Kussmaul's because it's a compensation, right? The patient is actually compensating for the ketoacidosis. So if I ask you what is the primary change in metabolic acidosis? Increase bicarbonate, increase PCO2, decrease bicarbonate, decrease PCO2. बताओ क्या होगा? Metabolic acidosis. First tell me how will be all the three? All three decrease because it's acidosis. pH कम, PCO2 कम, bicarbonate कम. उसमें हम asking you what is the primary? लंग का प्रॉब्लम है क्या? नहीं, मेटाबॉलिक है तो PCO2 प्राइमरी नहीं होगा. प्राइमरी क्या होगा? बाइकार्बोनेट. डिक्रीज की इंक्रीज, डिक्रीज, राइट? प्राइमरी इज बाइकार्बोनेट डिक्रीज. हाउ डू आई कंपेंसेट फॉर दिस बाइकार्बोनेट डिक्रीज? By increasing PCO2 or decreasing PCO2? साथ में जाते हैं दोनों. By PCO2 decrease. And how do I decrease the PCO2? By hyperventilation, right? So that's why there is hyperventilation. Now the question asked in the exam was, right, this was asked in NEET PG21 that I was mentioning कि एक diabetic patient है. Remember that diabetic patient, please do not jump to the answer directly. Diabetic ketoacidosis. ठीक है? The question was a diabetic patient, a pH of 7.7, bicarbonate 30, PCO2 48. What would be responsible for this? First, identify the acid-base disorder. What is it? pH increased is alkalosis. What alkalosis is this? Metabolic or respiratory? Metabolic. All three increased. So this is metabolic alkalosis, right? And the question gave that diabetic patient presenting with vomiting. Vomiting causes metabolic alkalosis. Why? Because in vomiting, what goes out? Acid. So what remains in the body? Alkali. So what will it lead to? Alkalosis. Remember, vomiting is alkalosis. While diarrhea causes acidosis. Remember, diarrhea is D, acidosis. डायरिया में एसिडोसिस क्यों होता है? क्योंकि जब डायरिया हो रहा है, इंटेस्टाइन में से क्या बाहर जा रहा है? Bicarbonate going out. There's chloride and bicarbonate change. So remember, it is acidosis. And what type of acidosis it is? Normal anion gap, right? We'll come to normal anion gap acidosis later. Remember that diarrhea is NAGMA, normal anion gap metabolic acidosis. A very frequently asked question, especially in the AIMS exam, where they give you a question where the pH is given normal. That means they give you that pH is 7.4. Whenever you see this pH 7.4, do not jump to the answer कि कोई acid base disorder नहीं है. It's a trap which is laid very frequently. So whenever the pH is normal, In the question, you are given the values of sodium chloride bicarbonate. Remember that the examiner is basically pointing towards that you have to calculate the anion gap, right? It's generally there. The answer is mixed acid-base disorder. It is hugma with alkalosis together. Can the pH be normal when there are two disorders? Acidosis decreasing, alkalosis increasing. So that means the pH will come to normal. Remember that normal pH does not rule out an acid-base disorder. It can be a mixed disorder with acidosis, alkalosis together. And they give you the values basically to calculate the anion gap. How do you calculate the anion gap? Cations minus anions or anions minus cations? Cations minus the anions. Remember that anion gap is due to unmeasured anions, not the cations. When I say the anion gap is because of the anions. Which anions? Which I'm not seeing. That is what is creating a gap. That is unmeasured. So which are the measured anions and which are the unmeasured anions? What do we normally measure is chloride and bicarbonate. These are measured. What are the unmeasured anions? The organic acid. और acid में कौन सा group होता है? What group does acid contain? COO minus. That means it's an anion. Minus मतलब anion. Normally, do we measure these organic acids? No. That means they are unmeasured anions. So example of that, lactic acid, formic acid, keto acid. So whenever these organic acids will increase, what will happen to the anion gap? अगर lactic acid बढ़ेगा, formic acid बढ़ेगा, keto acid बढ़ेगा, what will happen to the anion gap? Increase. Because you are increasing these unmeasured anions, so the gap is increasing. So lactic acidosis is hugma, high anion gap, metabolic acidosis. Formic acid कब बनता है? Methanol poisoning, right? Methanol forms formic acid. Keto acid is formed in diabetic keto acid. So all of these are causes of hugma, high anion gap. What are the measured cations? Sodium. Some books also include the potassium. So remember that anion gap is basically the measured cations minus the measured anions. That is sodium minus chloride and bicarbonate. This was asked in your INI-CT exam also, right? Calculating anion gap is important. Cations minus anions. Measured. So looking at the table here, now you know the entire table. Metabolic acidosis, the primary change will be bicarbonate or will it be PCO2? Bicarbonate. What will be the compensatory? PCO2. Bicarbonate decreasing, PCO2 decreasing. Metabolic alkalosis, primary change will be bicarbonate, increase bicarbonate. Compensatory change will be increase PCO2. In respiratory acidosis, what is the primary change? Respiration CO2 related है. Primary is CO2 change. Increase or decrease? Acidosis मतलब pH कम हो रहा है, तो respiratory में PCO2 क्या होगा? Increase. अगर ये increase हो रहा है तो bicarbonate increase. ठीक है? I hope this is clear. What is primary? What is compensatory? How will I decrease the PCO2? Hyperventilation. Right? So hyperventilation we see in metabolic acidosis. DKA याद रखना is hyperventilation. These are the normal values that we have already seen. So just look at the values. First is the pH and then you see the rest of the values to decide it is acidosis, metabolic or is it respiratory. This is the Winter's formula which is used as compensation in metabolic acidosis. कितना होना चाहिए? The compensation is by CO2. The compensated CO2 should be 1.5 into bicarbonate plus 8. right? Plus minus 2 is what is the formula. So compensation is something that you can skip. Like I said, it's not very frequently asked in the exam. Coming to the causes of respiratory acidosis, respiratory alkalosis. What are the causes of respiratory acidosis? Any cause of respiratory depression or hyperventilation. What will cause respiratory acidosis? Respiratory acidosis. Think logically. Acidosis मतलब pH क्या हो रहा है? Decrease. Respiratory है तो PCO2 क्या हो रहा है? Increase. When will the PCO2 increase? Hypoventilation. Any cause of hypoventilation, which is airway obstruction, opioid, sedative, depressing the respiratory center, respiratory muscles weak, all of this is acidosis, respiratory acidosis. Opposite, hyperventilation will cause alkalosis, respiratory alkalosis. When there is hyperventilation, panic attack, anxiety, high altitude, we hyperventilate, right? So please remember at least this, that high altitude is respiratory alkalosis because we hyperventilate, there is hypoxia. Anxiety, panic attack is hyperventilation. Salicylates stimulate your respiratory center and that is why they cause respiratory alkalosis. So if I ask you what acid-base disorder will you see with salicylates? Metabolic acidosis. क्यों? क्योंकि सैलिसिलेट क्या है? सैलिसिलिक एसिड है, राइट? तो ये करेगा एसिडोसिस. Because it is stimulating the respiratory center, it will cause respiratory alkalosis. So metabolic acidosis, respiratory alkalosis. What are the causes of metabolic alkalosis? Did we see alkalosis generally is associated with all K loss? That means hypokalemia. We saw the hormone. Which hormone? Aldosterone. Aldosterone causes alkalosis. Loop diuretics cause hypokalemia, cause alkalosis. Vomiting is acid going out, causes alkalosis. Right, so remember that these are the causes of metabolic alkalosis. This has nothing to do with the lung. So these are metabolic causes. Coming to metabolic acidosis, where you will have to check the anion gap. Why? Because metabolic acidosis can be normal anion gap or high anion gap. This was asked in your last INICET exam. Which acid-base disorder has maximum anion gap? Which one will be that? Metabolic acidosis. कहाँ बात करते हो high anion gap की? In metabolic acidosis, right? So maximum anion gap, metabolic acidosis. Check the anion gap. What is the normal anion gap? 8 to 12, right? Normal anion gap is 8 to 12. And what are the causes of normal anion gap metabolic acidosis? Remember diarrhea. Diarrhea is normal anion gap. So remember it as nagma, right? Normal anion gap metabolic acidosis. कौन है nagma? हमारी दीदी, nagma दीदी. That is diarrhea. You will remember is nagma. है ना? So any diarrhea. Diarrhea या तो intestine में से हो रहा है, diarrhea या तो kidney में से हो रहा है. ठीक है? तो GIT diarrhea, renal diarrhea. Renal diarrhea कब होता है? When I say renal diarrhea, basically what disorder am I talking about? When the renal tubule is defective, the renal tubule is not absorbing or the defect is gone. That means renal tubular acidosis. Renal diarrhea means renal tubular acidosis. Next point, how will I know that this nagma is GIT or this nagma is renal? What will we see now? Urinary anion gap. If the urinary anion gap is negative, it is a gut cause. That means GIT. Negative in GIT, positive in renal, urinary anion gap. Right, so remember that RTA is also normal anion gap metabolic acidosis with a positive urinary anion gap. Okay? And which RTA has hyperkalemia? Type 1 to 4? Type 4. Very important question. Hyperkalemia is seen in type 4 RTA. Remember that in 4, the potassium is more. और मच्छर मार रहे हैं. So remember that type 4, the potassium is more, hyperkalemia. So that means in RTA type 1, in RTA type 2, there is hypokalemia. Okay? So this is an exception. We said that hypokalemia is generally associated with alkalosis or acidosis. Alkalosis. But this is an acidosis with hypokalemia. Okay? RTA 1-2 is acidosis with hypokalemia. Which diuretics we said cause acidosis? कौन सा diuretic acidosis करता है? Acetazolamide और potassium sparing. ठीक है? So acetazolamide, spironolactone basically are your causes of normal anion gap acidosis. So you have spironolactone, you have acetazolamide. So acetazolamide is what RTA type? RTA type 2. Remember, this is RTA type 2. Because RTA type 2 is a proximal RTA or a distal RTA. Logically सोच के बताओ. कहाँ act करता है acetazolamide? PCT. That means it is proximal. It's a proximal RTA. So remember that type 2 is a defect in bicarbonate reabsorption defect. Right? So 2 is bicarbonate. So that's why this is acetazolamide type 2. Spironolactone is aldosterone antagonist. Aldosterone antagonist, aldosterone deficiency is RTA type 4. Spironolactone causes hyperkalemia, hypokalemia. Remember, it's potassium sparing. So it is increasing potassium. So this is what RTA? More potassium in 4. It is RTA type 4. So remember that RTA type 4, 4 is like which alphabet? A. So anything related to aldosterone excess की aldosterone deficiency. क्या करेगा acidosis? Deficiency की excess. Aldosterone causes alkalosis. So aldosterone deficiency will cause acidosis. Right? So tell me that cons will cause acidosis or Addison's will cause acidosis? Addison's. Because what is aldosterone or adrenal deficiency disorder is? Addison's disease. Remember, Addison, AD, is adrenal deficiency. Aldosterone deficiency, adrenal deficiency. Addison is aldosterone deficiency. That means it will cause acidosis. Cons will cause alkalosis. Cons will cause hypokalemia or hyperkalemia. Hypokalemia. Alkalosis, hypokalemia, hypernatremia is what you would see, right? Did we see diarrhea and renal tubular acidosis already? Right, the Nagma Didi wala. These are your Nagma causes, RTA, diarrhea, and all these causes basically are your types of RTA only. So all these are causes of normal anion gap. In normal anion gap, remember another cause is any cause of fistula, ureterosigmoidostomy. कहीं पे भी कुछ fistula हो रहा है, it is normal anion gap. Where there is nothing to do with the organic acids, the unmeasured anions, the anion gap, the anion gap is going to be normal. ठीक है? जहां पे ऑर्गेनिक एसिड्स आएंगे, when I say anion gap is increased, basically we are increasing the organic acids like formic acid in methanol, ketoacids in DKA, oxalic acid कौन सी पॉइजनिंग में देखा था? ethylene glycol, lactic acid. Did we see INH causes acidosis? Yes. What was that? Isoniacid. It causes acidosis. So ethylene glycol, propylene glycol, methanol, diabetic ketoacidosis, salicylic acid, all of these are causes of high anion gap. You don't have to mug up the causes, you need to understand the concept. Okay, isoniacid causes acidosis. Whether it is organic acid, it is high anion gap. Right, so done with the acid-base disorders. So tell me that at high altitude, what acid-base disorder will you see? High altitude. जब हम ऊपर जाते हैं, ऑक्सीजन कम है तो we hyperventilate, respiratory alkalosis. How should I compensate for respiratory alkalosis? Metabolic acidosis. Right? This is compensated by metabolic acidosis. Opposite. So which is the drug which causes metabolic acidosis? कौन सा diuretic? Acetazolamide. So that's the reason you can see that we give acetazolamide as a treatment in mountain sickness, right? Because it's compensating for that respiratory alkalosis. So acetazolamide, mountain sickness. Acetazolamide is used in the treatment or toxicity of which drugs? Acidic or alkaline? Alkaline. It makes the urine acidic or alkaline? It makes the urine alkaline or acidic? Alkaline, because the bicarbonate is going in the urine. If the urine is alkaline, it's an enemy of which drug? Acidic drug, right? So remember, acetazolamide is treatment of acidic drug toxicity. We have seen that already, correct? So you go to the exam hall, you see that there are difficult questions and you start panicking. What acid-base disorder will you get? क्या होगा? Respiratory, again alkalosis. Hyperventilate करोगे, respiratory alkalosis होगा. और remember, जब respiratory alkalosis होता है, there is hypocalcemia. Hypocalcemia is seen in respiratory alkalosis, and because there's hypocalcemia, there'll be features like tetany, right? The question generally mentions like tingling, numbness, perioral. These are features of hypocalcemia, is common in respiratory alkalosis. एम्फाइसेमा में क्या दिखेगा? Which acid base? एम्फाइसेमा. अच्छा, पहले रेस्पिरेटरी की मेटाबॉलिक, रेस्पिरेटरी. लंग का प्रॉब्लम है, रेस्पिरेटरी. एसिडोसिस, अल्कलोसिस. Because emphysema basically comes under your COPD, obstructive, so it's a hypoventilation, so it's going to cause acidosis. Remember, emphysema is respiratory acidosis. Right, that is about the acid-base disorder. Coming to the autoantibodies. Which antibody you see in which disorder? Myasthenia gravis we have already seen is antibody against acetylcholine receptor. Presynaptic, postsynaptic? Postsynaptic. What type of receptor is this? NM, right? Neuromuscular junction, NM. Versus Lambert-Eaton. Presynaptic. Which channel antibody? Calcium. Voltage gated calcium channel. So remember that alphabetically L comes before, M comes बाद में. So Lambert-Eaton is pre, myasthenia is post. This is presynaptic calcium. This is postsynaptic acetylcholine. Antiphospholipid syndrome, that's basically your APLA. So you have anti-beta-2 glycoprotein as well as anti-cardiolipin and lupus anticoagulant, right? In APLA, the history generally given in the question is recurrent abortion. Right, APLA, recurrent abortions. APLA is lupus anticoagulant and anti-cardiolipin. In SLE, what is the screening antibody? ANA, right? Anti-nuclear antibody. If you see clinically also, if you've seen in internship, yeah, clinics, mein, ANA antibody is positive in almost all the autoimmune disorders. So it is very non-specific. That means it's just a screening test. Screening test is not a specific test, right? If ANA is positive and then I want to prove that this is SLE, then which antibody will I look for? Smith. Anti-Smith antibody is a specific one. So dsDNA in SLE, remember that the more specific antibody is anti-Smith. And what is the role of anti-dsDNA? To look for the activity of the disease. You know whether the SLE is now acutely active. The dsDNA basically is for activity. So for activity of SLE, we do the anti-dsDNA and we can also look for what levels? The complement levels. Right, the complement levels decrease. Anti-histone antibody. Histone is a drug history. Histone is drug history. So basically this is drug-induced SLE. For MCTD, that is mixed connective tissue disorder, remember mixed, matlab universal. Mixed is universal. So we have anti-U1 RNP, universal. Remember mixed matlab jaise universal. So it is U1. Anti-U1 RNP is mixed connective tissue. Rheumatoid arthritis, we have rheumatoid factor and the more specific is anti-CCP. CCP is more specific for rheumatoid arthritis. The question asked for rheumatoid factor is it a IgG or is it a IgM? It's a IgM antibody against IgG ka FC region. Right? Whenever there's an immunoglobulin, right, the antibody has a heavy chain, the light chain. It has a region which binds to the complement. So basically IgG के FC region का antibody, IgM antibody is rheumatoid factor. So remember that rheumatoid is M. It's a IgM against IgG. Anti-Rho, anti-La are positive in Sjogren's. Remember anti-Rho, anti-La is Sjogren's. Anti-Rho is anti-SSA, La is anti-SSB. SS you can remember as Sjogren syndrome. SSA, SSB is Sjogren syndrome. Sjogren syndrome हमने कल ऑफ्थाल में कहीं देखा था? Dry eyes, right? Dry eyes, dry mouth, salivary gland enlargement. All these features are seen with Sjogren's. Scleroderma, which is a diffuse systemic sclerosis, like scleroderma is what antibody? SCL. Remember scleroderma is SCL. Anti-SCL70, which is basically anti-DNA topoisomerase. What was the drug for anti-topoisomerase 1? One was Thicans, right? And 2 was etoposide. Topoisomerase 2 was etoposide. If it's a limited scleroderma, that is the CREST syndrome. Limited scleroderma is CREST syndrome. C for C. What antibody you have in crest? Anti-centromere. C for C, anti-centromere. In scleroderma, in crest, remember the question generally gives you history of Raynaud's. Right, remember crest, calcinosis cutis, Raynaud's, esophageal, dysmotility. So there is history given of dysphagia. ठीक है, तो जब Raynaud's और dysphagia का history होगा, they are pointing towards scleroderma. Polymyositis, dermatomyositis is anti-Jo. Okay, anti-Jo antibody. There can be anti-Mi2 as well, which is basically anti-helicase. So dermatomyositis, polymyositis is anti-helicase, anti-synthetase, that is anti-Jo and anti-Mi2. What tumor marker will you test for in dermatomyositis? You need to test for which tumor marker? CA 125, because there is increased risk of what cancer? Ovarian cancer. Right? Important. Dermatomyositis, paraneoplastic syndrome is ovarian cancer. CA 125 needs to be tested. So remember, the name of this female who has ovarian cancer is Jo. Jo has ovarian cancer, dermatomyositis. Anti-mitochondrial, that is AMA. Anti-mitochondrial, that is AMA antibody is primary biliary cholangitis. So in primary biliary cholangitis, basically the age group affected is a female, right? A female, an adult female patient presenting with any biliary obstructive cause, presents with what features? Pruritus, obstructive jaundice, pruritus. Right? Remember, pruritus is the important feature of any obstructive cause, right? The obstructive biliary cause. You will test for AMA, anti-mitochondrial. If it is autoimmune hepatitis, you look for LKM. LKM antibody, that is liver kidney microsomal. LKM antibody, liver is affected, autoimmune hepatitis. Now this is important, that's basically your P anka, C anka. Where is P anka positive? Where is C anka positive? C is, where is C anka? Vaginous, which is now called as granulomatosis with polyangiitis, GPA. Remember that vaginous is C anka. So it is, remember, vaginous, VC. Okay, VC. And the C anka is anti-MPO or anti-proteinase 3. What is C anka? PR3, that is proteinase 3. So remember, this is anti-proteinase. C is the third alphabet. So this is anti-proteinase 3. This is C3. Right? Vaginous, VC, that is C anka. The rest of these vasculitis, microscopic polyangiitis, right? Eosinophilic granulomatosis with polyangiitis. That's basically which one? Where you have eosinophilia? कौन सा होता है? Church cross. Right? Church cross is eosinophils. Ulcerative colitis, all this is P anka. Okay, this is, the rest of them is P anka, C anka is vaginous. In which nephrotic syndrome, renal pathology, you see anti-phospholipase A2 receptor antibody? Membranous, membranoproliferative, PSDN, किसमें दिखता है? Membrane. Did we see that the cell membrane contains the phospholipid? Yes. So remember that phospholipase is the membrane. the cell membrane. Where did we see this? Phospholipase being inhibited. Which condition? Asthma dekha, steroids, locks and cocks, right? Correct. Locks and cocks. Bullous pemphigoid, pemphigoid vulgaris. Out of these, which one has the flaccid bulla, which is tense bulla? Pemphigus vulgaris is flaccid. Which is more superficial? Vulgaris pemphigoid. So remember that vulgaris is S superficial, pemphigoid is deep. Superficial bulla are flaccid bulla, deep bulla are tense bulla. Right, so remember that pemphigus vulgaris is anti-desmoglein, the DSG, that is anti-desmosome, while bullous pemphigoid is hemidesmosome. Pemphigoid ID is DI. You divide it into 2, that's hemi. Pemphigoid is hemidesmosome. This is desmosome. Coming to thyroid, Hashimoto's and Graves. इसमें कौन सा antibody मिलता है? Hashimoto's, if you have seen, if you've had any of your relatives, anybody known who has hypothyroidism. This is a very, very common cause of hypothyroidism that we see. And the most common antibody that you will see positive here is anti-TPO. Thyroid peroxidase. Anti-TPO. TPO antibodies. So किसी को भी hypothyroid होगा, you test for this anti-TPO antibodies. Right, so it is anti-thyroglobulin or anti-TPO, while Graves is hypothyroid or hyperthyroid. Hyperthyroid, because you have LAX, the long-acting like thyroid stimulator, which stimulates the TSH receptor. The antibody here is against the TSH receptor. The antibody here is against the TSH receptor. Celiac disease associated with which skin condition? Dermatitis herpetiformis, right? Dermatitis herpetiformis. What HLA is associated with celiac? DQ2 है ना. अगर आप celiac disease का patient है, अगर हमारे पास आएगा, so we will tell the relative when you knew that the patient has celiac, so wheat DQ2, तो पता था कि celiac है, तो wheat DQ2, that is DQ2. Remember, it's DQ2 and DQ8 also. DQ2, this was asked in the recent exam, important, DQ2. What HLA did we see in myasthenia gravis? Remember myasthenia gravis? B8, right? Mahatma Gandhi ka chashma, that was B8, this is DQ2. So celiac disease, what antibodies we get here is anti-endomycin, anti-TTG, tissue transglutaminase, TTG. ये पूरे नाम याद मत करना क्योंकि एमसीक्यू एग्जाम है, कोई सब्जेक्टिव एग्जाम नहीं है, ठीक है. सो जस्ट रिमेंबर टीटीजी, टिश्यू ट्रांसग्लूटामिनेस, एंटी एंडोमाइसिन, right? So this is gluten sensitive enteropathy. Wheat is not to be given. Type 1 diabetes is what antibodies? GAD. What is GAD? Glutamic acid decarboxylase. Glutamic acid decarboxylase. In type 1, the islet cells are affected. So basically this is islet cell or GAD. Pernicious anemia. कौन सा cell affected? Parietal cell. Anti-intrinsic factor, anti-parietal cell. Good pastures is anti-GBM, glomerular basement membrane antibody होती है. So tell me, good pastures, what immunofluorescence do you get? Linear or granular? Linear. If I see a linear immunofluorescence, basically it is telling me that this is antibody mediated. It is not immune complex mediated. Right? It is linear immunofluorescence. It's a key word here. In good pastures, the basement membrane affected is the glomerular basement membrane and the alveoli, the Lanka basement membrane. So basically there is hematuria with hemoptysis. There is hematuria with hemoptysis. If it is antibody mediated, this is what? Hypersensitivity. Type 2. Antibody. Body is just the type 2. Right? The B is the 2. Antibody is type 2. So this is affecting what type of collagen? Good pastors, collagen type. What do you have in basement membrane? 4. Basement membrane is the floor. It has what collagen? 4. Floor has 4. So it is the antibody basically affecting collagen type 4. Which chain? Which chain? Alpha 3 alpha 5. Alpha 3. Remember what gene is it? It is called 4A3. Collagen 4 alpha 3. Remember the mnemonic for good pasture syndrome is 1, 2, 3, 4. What is 1? It is type 1 RPGN. It is type 2 hypersensitivity. It is alpha 3 chain of which collagen? 4 collagen. Right, so good pastures is 1, 2, 3, 4, 1 RPGN, 2 hypersensitivity, alpha 3 chain and collagen type 4. Right, so these are the various antibodies. It's important to know all the clinical features also in these conditions because that's how you'll be able to identify. So knowing the presentation is also important. Okay? Coming to CSF meningitis, it's bacterial, viral, fungal. What is the first thing I look for whenever I'm given a case of CSF? सबसे पहले क्या देखेंगे? Glucose. Because if I see normal glucose, it is going to be viral. Remember that viruses do not eat glucose. That's how you remember. So the CSF glucose will remain normal. Bacteria, fungi, they will eat the glucose and decrease the CSF glucose. So अगर normal glucose है, it's viral. If the glucose is not normal, the glucose is decreased. Then I'll see at the cells. What cells are increased? If it is increased PMN, that's basically the neutrophil increased. When are the neutrophils increased? Bacteria. Right? Bacteria, acute inflammation, acute infection, it is neutrophils increased. If the lymphocytes are increased, then it can be TB or it can be fungal. Fungal meningitis, basically the history would be of immunocompromised patient. Fungal infections are seen in immunocompromised. Right? So HIV positive or immunocompromised patient. TB may, there will be history of basal exudates. What coagulum? Cobweb. Right? The cobweb appearance, basal exudates. And you will see this lipid peak on MR spectroscopy. Right? What peak do you see in TB on MR spectroscopy? Remember lipid. Mycobacteria, remember, has lipid, mycolipid. So it shows a lipid peak. MR spectroscopy, lipid peak. So fungal will be immunocompromised. This is TB patient with lipid peak, basal exudates, cobweb. What is the drug of choice for fungal? That is cryptococcal meningitis. It is amphotericin B, right? LAM, liposomal amphotericin B, and you give it along with fluconazole or flucytosine. Flucytosine, not fluconazole. Once this is done, the initial induction phase, Then for the maintenance, you give fluconazole. Why fluconazole only? Because this crosses the blood-brain barrier. The azole which crosses the blood-brain barrier is fluconazole. So remember, first is amphotericin B, flucytosine, again asked in one of the recent INICT exam. So in the CSF, the meningitis, if the glucose is normal, it is viral. If it is the PMS increased, it is bacterial, right? Rest will have the lymphocyte increase. That is what you need to look at. If it is the albuminocytological dissociation, what do we mean by that? Albumin increased, but the cells are normal, right? Whenever the proteins are increased, I think of infection, I think of increased cells. But I find that the cells are normal, then it is GBS. Right, Guillain-Barré syndrome, because it's not a primarily an infection, it's an immunologic thing happening. So remember, the cells will be normal here. It is associated with what infection? Campylobacter. GBS is an ascending or a descending neuropathy? Ascending. Start from the lower limb, ऊपर ऊपर आता है. Then what is the most common cause of death? Respiratory. Most common cause of death, ascending one, it involves the respiratory muscles. The respiratory muscle failure. Oligoclonal bands are seen in multiple sclerosis. Oligoclonal bands, multiple sclerosis, which on MRI shows dorsal fingers. If this is a sagittal MRI, you would see the demyelinating plaque like these fingers. That is the dorsal fingers. Multiple sclerosis affects the gray matter or the white matter of the brain. Gray ki white. It's a demyelinating disorder. So demyelinating means what? White matter. Right? Myelin white matter mein hota hai. Gray matter are the cells. So it's a white matter disorder. Listeria and HSV. Herpes simplex virus affects what lobe in the brain commonly? Temporal, as in the recent exam. Temporal lobe, whenever you see involved, HSV. Right, and HSV generally causes meningitis, which is hemorrhagic. There's going to be blood in the CSF. Right, it's a hemorrhagic encephalitis. The treatment here, drug of choice is acyclovir. It's nephrotoxic, so you need to check creatinine before giving acyclovir. While listeria, common cause of neonatal meningitis, especially if there is history of premature rupture of membranes. Very important, what is the drug of choice for listeria? Ampicillin. Okay, it is ampicillin, which is the drug of choice. Listeria is gram positive, gram negative. It is gram positive. Okay, it's a gram positive bacillus. It's a gram positive bacillus. It shows what motility? Tumbling motility. The selective media for listeria we'll see in microbiology is talcum. Talcum media. Right, so remember listeria and HSV along with this CSF meningitis. Coming to the last one here, this is flashcards. Don't think this medicine itna hi hai, because many of this, the rest of the topics are covered in patho, like your infective endocarditis, anemia, lymphoma, hematology, वो सब patho में cover करेंगे. So looking at the quick one-liners, the flashcards, which are very, very important. Only serological marker present during the window period in hepatitis B is anti-HB. C. Again, we are going to see hepatitis B serology in microbiology. So remember that C is constantly present. The marker which you will always see in a case of hepatitis B infection is NTHBC. Rod spots are seen in infective endocarditis. Cannon A waves. Remember Cannon A waves, which are very, very tall A waves, will be seen in a case of heart block. Again, this we are going to see in JVP. Did we see hyperkalemia is a feature of which RTA? 4. 4 is more. Which cancer causes polycythemia? कौन सा कैंसर? पॉलीसाइथेमिया. आरबीसी. आरबीसी बढ़ाने के लिए क्या लगता है? एरिथ्रोपोइटिन. कहां से आता है एरिथ्रोपोइटिन? किडनी में से. सो रीनल सेल कार्सिनोमा. Nodular glomerulosclerosis is a pathognomonic feature of diabetic nephropathy. What are these lesions called as? The KW lesions. Kimmel-Wilson lesions, right? So nodular glomerulosclerosis is the KW. Very important, was asked in the recent exam. PRCA, that is pure red cell aplasia, is associated with which tumor? Thymoma. And thymoma is seen in which condition? Myasthenia gravis. Remember, PRCA is thymoma. What is the initial investigation of choice in DVT? Deep vein thrombosis. You want to see the thrombus in the vein, you will do the USG, duplex USG. That's basically a Doppler, right? It's a Doppler. And what is the history in DVT? Who develops DVT? Bedridden, immobilized patient, right? So the history will be of bedridden patient. Which disease is called as pulseless disease? Takayasu, right? Pulseless disease, upper limb pulseless disease, Takayasu. Because what is the most common artery affected in Takayasu? Subclavian. So the upper limb pulse will go. Anion gap, is it increased or is it normal in RTA? In RTA, the anion gap is normal. Remember, it is not increased. Nagma is diarrhea, renal diarrhea, GIT diarrhea. Metabolic alkalosis is generally associated with all K loss, hypokalemia. In CHPS, will you see alkalosis or acidosis? Alkalosis, acidosis. Alkalosis, because there is vomiting, acid going out. Hypokalemia, hypochloremia. It is hypokalemic, hypochloremic alkalosis with paradoxical aciduria. Paradoxical aciduria. What condition is a granulomatous condition and presents with hypercalcemia? Sarcoid. Important. Remember, there is hypercalcemia in sarcoidosis. For sarcoidosis, the key word given in the question is bilateral hilar lymphadenopathy. Very, very important. Sarcoidosis is bilateral hilar lymph node with hypercalcemia. There is increased what levels? ACE levels. ACE levels, calcium levels increased. Disease causing orchitis, mumps, right? It affects the parotid, parotitis, orchitis. Conn syndrome is hyperaldosteronism. If the aldosterone is increased, there will be hypokalemia or hyperkalemia. Hypo, right? Remember, aldosterone is alkalosis, all K loss, hypokalemia. The commonest cause of paroxysmal hypertension. Sudden hypertension हो रहा है, pheochromocytoma, the norepinephrine, epinephrine coming in, There is history of paroxysmal hypertension, headache, sweating, palpitations. Right? All the sympathomimetic clinical features. And for pheochromocytoma, what nuclear scan do you do? MIBG? MIBG scan? डोटा स्कैन भी कर सकते हो या डोपा पेट भी कर सकते हो. Remember DOTA, DOPA and MIBG. HSP, Hinod-Schonlein purpura, has what Ig deposition? IgA. Right, in HSP, what is the history? There's a triad of palpable purpura, joint pain, abdominal pain. Right, that's a classical history. We'll see that in vasculitis again, the HSP. In hemophilia, the bleeding that you see is a spontaneous bleeding. And where is the bleeding? Is it ecchymosis or is it hemarthrosis? Hemarthrosis. Remember, hemophilia is hemarthrosis. That is joint में pain bleeding होगा because it's a clotting factor disorder. If it's a platelet disorder, then we see the ecchymosis and the purpura, right? Which hemophilia is autosomal recessive? Hemophilia C, right? Hemophilia C. Medullary thyroid cancer is seen in which men syndrome? MEN2. MEN2A, MEN2B both. Remember, medullary, med in men. Which thyroid cancer is seen in men syndrome? Medullary. What is the tumor marker for medullary? Calcitonin. The drug of choice in CML is imatinib. Tyrosine kinase inhibitor there, it is imatinib. CML is imatinib. Emphysema, we already saw is what disorder? Respiratory acidosis, because it's an obstructive pathology. Pneumococcal is common in which pneumonia? Staphylococcal pneumonia. Important, pneumococcal. Anti-endomysial antibody? Celiac. Which other antibody? Anti-TTG. Tissue transglutaminase, anti-endomysial. Alpha-1 antitrypsin deficiency affects the liver, right? Chronic liver disease, plus it also causes emphysema. What kind of emphysema? Pan-acinar. Pan-acinar emphysema. Wilson's disease has urinary copper increased because Wilson's may the copper is in excess. So the urinary copper also increases. What decreases is serum ceruloplasmin. The urinary copper increases, the liver copper deposition increases, ceruloplasmin is decreased. Drug of choice for trigeminal neuralgia is carbamazepine. Right, carbamazepine for trigeminal neuralgia. What condition is this? Where you have episodic flushing, diarrhea, wheezing. Carcinoid. Remember carcinoid. Where in carcinoid what increases? Serotonin. What comes from the metabolism of serotonin is HIAA. Serotonin comes from which metabolism? Trypto. Seroto is trypto. Right? So remember, it has increased urinary HIAA. Carcinoid can cause which vitamin deficiency? Niacin, right? B3, because दोनों आ रहे हैं tryptophan से. Carcinoid affects generally what valve in the heart? Right side. Important, remember right-sided valve is affected. Tricuspid regurgitation, pulmonary stenosis. When you have a patient who has cirrhosis, who has diabetes, who has skin pigmentation, Basically, this is bronze colored skin with diabetes. It is a case of hemochromatosis. Excess iron in the liver, in the pancreas, causing diabetes in the skin. That is bronze diabetes. Hemochromatosis. Hemochromatosis, what is the inheritance pattern? Primary hemochromatosis. Hemo, homo, कौन है homo? Wilson. कौन सा disorder था वो? Autosomal recessive. What gene is it? Hemochromatosis is increased iron. So it is what gene? HFE. Remember, it is HFE gene. On what chromosome you have this HFE gene? Remember, Iron Man. Iron Man is having the 6 packs. It is chromosome 6. So Iron Man with the 6 packs. It is chromosome 6. Onion peel bile duct fibrosis is seen in primary sclerosing cholangitis, which on MRCP shows what appearance? Primary sclerosing. Basically, there are multiple strictures. Beaded appearance. Beaded appearance. Right? The multiple strictures in primary sclerosing cholangitis. When you do the histopath, the strictures basically is fibrosis, onion peel fibrosis. Onion peel lysosomes is Tay-Sachs, sac of onion. And primary sclerosing cholangitis is generally associated with which condition? Ulcerative colitis. Very important. Ulcerative colitis. High levels of IGF-1 will be seen in which endocrine disorder? Acromegaly. Remember, insulin-like growth factor is when there is increased growth hormone. So remember, GF is GH. Increased growth hormone. Acromegaly is increased IGF-1. For which condition you do water deprivation test? Diabetes insipidus. Diabetes insipidus presents with, what is the clinical history given? Any diabetes. Remember, insipidus or mellitus basically will present with polyuria. Okay, this will present with polyuria. So, be it diabetes mellitus, be it diabetes insipidus. In diabetes mellitus and in diabetes insipidus, how is the urine osmolality in diabetes insipidus? Urine osmolality is low or high? In diabetes mellitus, what is going in the urine? Glucose. In diabetes insipidus, what is going in the urine? Water. ADH is just related to water. तो इसमें सिर्फ पानी जा रहा है यूरिन में. पानी जा रहा है तो मतलब ऑस्मोलालिटी क्या है? Low. Urine osmolality is low. Plasma osmolality is high. While here, because it's glucose, that means the osmolality will be high. So remember that diabetes insipidus is low urine osmolality. So you do this water deprivation test for water wala hormone, that is ADH wala condition, which is diabetes insipidus. Okay, that's diabetes insipidus. So that does not complete the medicine part. What is that one topic remaining in medicine? JVP. वो खत्म करके फिर आगे देखिए. क्या है JVP? पेज नंबर, मेडिसिन वाला नहीं, फिजियोलॉजी वाला. पेज नंबर 15. Page number 15. Right, so JVP basically tells me the pressure in which chamber of the heart? Right atrium. Okay, right atrium. राइट एट्रियम का प्रेशर सुपीरियर वीना केवा में जाएगा, वो इंटरनल जुगुलर वेन में जाएगा. सो रिमेंबर जेवीपी वी मेजर इन द दिस इज आईजेवी नॉट द ईजेवी. एक्सटर्नल जुगुलर वेन नहीं, इंटरनल जुगुलर वेन. So if the right atrium pressure increases, the JVP will be high. So normal JVP, what waves do you see and what descents do you see? A, C, B is positive, X and Y is the descent, the negative. Now, what is the A wave due to? Atrial contraction. A for A. A wave is due to atrial contraction. When the atrium contracts, what will happen to the atrial pressure? Atrial pressure will increase. So A wave is a positive wave. C wave is due to C for cusp, C for contraction. C for cusp, C for contraction. कौन सा contraction? Isovolumetric contraction of the ventricle. So when the ventricle contracts, what happens to the tricuspid valve is the pressure in the ventricle pushes this tricuspid valve up. So the cusp bulges into the right atrium, the cusp comes up, the pressure comes up, and the JVP also shows a positive wave. So remember, it's because of the tricuspid valve bulge in isovolumetric contraction, basically, which is, when I say the ventricle is contracting, it's a systole. What is the X descent due to? X is relaxation. It is the atrium relaxing. V is due to venous return. The venous return coming into the atrium. And what is Y due to? Emptying. Y is the emptying. Emptying the atrium into the ventricle. So the terms, the letters itself help you to remember. A is atrial contraction. C is cusp or contraction of ventricle. X is relaxation. B is venous return. Y is empty. Now let's look at what wave of these will come in systole, what will come in the diastole. Now remember that when we say systole or diastole, by default it means ventricular systole, ventricular diastole. Okay? So when the atrium is contracting, is it a systole or a diastole? Diastole. Remember, it's like a seesaw in the heart. If the atrium is contracting, the ventricle is not contracting. So if the atrium is contracting, it's basically a ventricle not contracting, it's a diastole. Logical सोचो जब atrium contract हो रहा है. Why is the atrium contracting? Why does the atrium want to contract? To pump that blood in the atrium into the ventricle. That means the ventricle is getting filled. When does the ventricle get filled? Systole or diastole? Diastole. So remember that atrial contraction is a diastole. Is it an early diastole or a late diastole? Late. Atrium पहले से contract नहीं करता है. Diastole starts with the pressure difference leading to the blood going into the ventricle. फिर जो आखिरी में बचा कुचा blood है वो push करने के लिए the atrium contracts. So remember that atrial contraction is late diastole, right? The early emptying will give what wave in JVP? Emptying is what wave? Y descent, right? Emptying. So when I say the atrium is getting empty into the ventricle, it's a systole or a diastole? Diastole. Early or late? Early, which is just because of the pressure difference, right? Tricuspid valve contraction, it is your first early systole, isovolumetric contraction. That means when the systole is starting. So C wave is systole. X is relaxation. When the atrium is relaxing, is the ventricle relaxing? It's a seesaw. Atrium relax करेगा तो ventricle relax नहीं करेगा. So atrium relaxation is a systole or a diastole? Opposite. Ventricle contraction, it's a systole. Venous return. When does the venous return come? In the systole or the diastole? जब यहाँ पे सिस्टोल चल रहा है, by that time the atrium is getting the blood from the veins, right? It is getting filled. So it is just before the onset of diastole. That means you can call it as late systole. It is late systole. Now ये सब अगर याद नहीं करना है, you just want to remember with the tricks. Remember that in diastole, what do you see in diastole and what do you see in systole? So diastole, write it as diastole. So it is the Y and the A that you see in diastole. Rest of it you see in systole. So diastole में क्या आता है? Diastole, the Y and the A. Right, Y and A. स्पेलिंग में ही देखोगे diastole में तो पहले क्या आ रहा है? Y. फिर क्या आ रहा है? A. So which is the early diastole? Y. Which is the late diastole? A. बाकी फिर कौन सा बचेगा जो सिस्टोल में आएगा? C X B. Remember, it is C X B. So if you look at this JVP waveform here, C X B. This is what is your systole. Where is the systole starting? C. Remember, systole starting means the contraction starting. So it is C. Contraction is the C. So systole starts with the C. What heart sound is it when the systole is starting? S1 ki S2? S1. Again, remember with the trick that S2 is die. So S2 indicates the diastole onset. So S1 will indicate the systole onset. Right? So remember that C is where the systole is starting and V is where the systole is ending or the diastole is starting. In the middle is the X, C, X, V. So remember that V wave corresponds to what heart sound? S2. हमने देखा ना कहीं और भी V is 2. We had seen somewhere yesterday. I was telling you that V is 2. Sorry? Which was that? कहीं तो देखा था जो मुझे भी आती है. And I told you that we'll see it somewhere else as well. So remember that V basically is 2. So it is S2. Okay, that is S2. So remember that V is S2, that is diastole. C is contraction, it is systole, that is S1. Okay, that is S1. So that is about the physiology part of JVP. Right, it is given here similarly. C is S1 and isovolumetric contraction. V and S2 go together. That means this is where the diastole is starting. When the diastole starts, early diastole, what wave are you seeing? Diastole. क्या दिखेगा सबसे पहले? Y descent. A कहाँ पे दिख रहा है? यहाँ पे. Before the C. Right? So that is the A wave. Now A wave is because of atrial contraction. What precedes the atrial contraction? Atrial depolarization. So which wave? P wave. So पहले P wave आएगा, उसके बाद क्या आएगा? A wave. ठीक है? So this is about your JVP. What is in systole? What is in diastole? Constrictive pericarditis, cardiac tamponade. What do you see in JVP? किसमें एक वेव एब्सेंट है? टेम्पोनाड में कि पेरिकार्डाइटिस में? एक्स और वाई में से किसमें एब्सेंट है? टेम्पोनाड. Remember that constrictive pericarditis is CP. CP मतलब combined present. दोनों present है. यहाँ पे कुछ absent नहीं है. So where is it absent? It is absent in tamponade. What is absent in tamponade? Y is absent in tamponade. Remember in constrictive pericarditis, it is CP, combined present. So now if we go back to your medicine wala part, the JVP abnormalities. Page 197. So coming to the pathologies, So Canon A wave. Remember, Canon A waves are seen in complete heart block. Did we see anything in ECG in complete heart block? What will you see in complete heart block? RR is constant or changing? Constant. RR is constant, PP is constant, but P can overlap R, P can overlap T, कुछ भी हो सकता है. So in complete heart block, basically what is happening is the atrium is contracting even when the valve is closed. The tricuspid valve is not open because it's a heart block. इनको कुछ फर्क नहीं पड़ रहा है, अपने हिसाब से कर रहे हैं. ठीक है? So when the atrium will contract against a closed valve, a closed door, the pressure will increase significantly. That will give the Canon A wave. It's basically because atrium is contracting against closed valve. The pressure will increase significantly. That is Canon A wave. If it is not a closed valve, but it's a narrow valve, will the pressure increase again? Yes. So what will you see? Large A wave. So which condition will you have large A wave? When basically there is any obstruction to the right atrium. When the right atrium is contracting against an obstruction, so that is tricuspid stenosis, pulmonary stenosis. Right? Where will you have absent A wave? जब atrium contract ही नहीं कर रहा है, क्योंकि A wave is contraction. कब atrium contract नहीं करता है? Fibrillation. Right? Basically the atrium is hardly contracting. So it is absent A wave. Pericarditis and cardiac tamponade, right? Constrictive pericarditis, we said that it is CP, combined, present. So none of that is absent. X is also present, Y is also present. Rather, you would see a steep Y descent. So what is getting affected is your Y. In the cardiac tamponade, there is absent Y descent. So remember it as pay tax. What is pay tax? Pay tax basically stands for in pericarditis. It is A here is not absent. Remember in pay tax, A is for aggravated. It is increased Y descent. In tamponade, it is tax. It is increased X descent. So remember pay taxes, pericarditis aggravated Y, tamponade aggravated X. In pericarditis, it is combined present, both is present. In tax, if the X is prominent, the Y is absent. So very important, this is absent Y. And in cardiac tamponade, what triad do you have? Beck's triad. What is a Beck's triad? JVP, heart rate, heart sounds. Basically, remember everything connecting to the heart and including the heart. Veins, then you have the heart and you have the artery. So related to the vein is JVP. Related to the heart is the heart sounds. And related to the artery is the blood pressure. So vein, heart, artery, all affected is your Beck's triad. Seen in cardiac tamponade. Muffled heart sounds, decreased blood pressure and increased ABP. Can pneumothorax also cause this? Increased JVP with decreased blood pressure? Yes. What kind of shock is it called as? Obstructive shock. है ना, pneumothorax basically can cause obstructive shock because जब बहुत ज़्यादा pneumothorax होगा, heart को compress करेगा. If the heart is compressed, back pressure, the JVP will increase. Right? Shock मतलब blood pressure कम हो जाएगा, तो blood pressure कम होगा, JVP बढ़ेगा. So how do I differentiate pneumothorax from cardiac tamponade? Pneumothorax is related to the lungs, so they will be absent breath sounds. Right? So it's the breath sounds that you have to look for. Tamponade में लंग को कुछ नहीं हो रहा है, the breath sounds कुछ नहीं होगा, यहाँ पे breath sounds absent हो. What do you see in ECG in cardiac tamponade? Cardiac tamponade means the heart floating in the fluid and blood around. Right? So imagine that this is the heart and floating in the fluid. So when you take a ECG, कभी ये हार्ट फ्लोट करके आगे आएगा, कभी ये पीछे जाएगा, तो क्या होगा, जो एम्पलीट्यूड आ रहा है ECG में, sometimes it can be more, sometimes it can be less, because it depends on the distance between the electrodes and the heart, right? So remember that this is called as electrical alternance. There is alternating amplitude. So remember, not just cardiac tamponade, any cause of pericardial effusion basically will have this electrical alternance. Do not confuse this with pulsus alternance. Where do you see pulsus alternance? Left ventricular failure. Pulse is related to the heart ka contraction. Okay? So when the heart fails, left ventricular failure, there is pulsus alternance. What did we say happens to JVP in tricuspid stenosis? Tricuspid stenosis होगा तो क्या होगा? A wave, large A wave. और जब tricuspid regurgitation होगा तो क्या होगा? When there is tricuspid regurgitation, what is happening? Is the atrium getting any time to relax? क्योंकि ये बंद ही नहीं हो रहा है दरवाजा, so the atrium is not getting any time to relax. So what is absent? Exdecent. There is no relaxation. The atrium is not getting any time for relaxation due to regurgitation. So the X is absent. X is relaxation. In the JVP, you have the A wave, then you have C. What do you have next? What is the sequence in the JVP? A के बाद C, फिर X, फिर V, फिर Y. CXV is basically what in the cardiac cycle? Systole. If the X is absent, that we are saying in tricuspid regurgitation, so what will happen? The C will combine with the V. So what will you see is CV wave. Important question. CV. That means the X is absent. So CV wave is seen in tricuspid regurgitation. What will happen to the V wave? What does the V indicate in JVP? V for venous return. So whatever blood is coming to the right atrium, normally वो vein में से आ रहा है, SVC, IVC. What else is contributing in regurgitation? The tricuspid regurgitation. Right? So remember that the V wave will increase due to increased venous return, basically due to regurgitation. अभी वो SVC, IVC से तो blood आ ही रहा है, साथ में ये regurgitation से भी आ रहा है. So the venous return is increased, so the V wave is also increased. So you can get a question like, all of the following are true about tricuspid regurgitation JVP findings except. So remember, it's the X which is absent, the V which is increased, and the CV wave. Did we see what waves in JVP occur in diastole? The diastole. Right? What happens in diastole? Y and A. Y is early, A is late. What wave indicates the onset of diastole? Di is what heart sound, what wave? Di matlab S2. What wave? 2 matlab V. Right? So remember, it's the S2 and the V. S2 and V is the onset of diastole. Correct this is C wave is onset of diastole or systole? This is not diastole, this is systole. C matlab C for contraction. That's the systole. Okay, the C wave is the onset of the systole. What is this X-ray image showing? क्या दिख रहा है X-ray में? Constrictive pericarditis. Why? Because there is. Can you see this white line surrounding the heart? What does the white indicate here? Calcification. Right? So this is basically the calcification suggestive of constrictive pericarditis, right? We talk about CCP, calcific constrictive pericarditis. So what will you see in the JVP? CCP, CP में क्या दिखेगा? Combined present, deep, wide descent, right? What do you see on auscultation in constrictive pericarditis? Remember, there's something called as pericardial knock, and the small sign is what you see in constrictive pericarditis. So remember that constrictive pericarditis has the K and the K, which is knock and small. The pericardial knock. When does the pericardial knock occur? Basically, when the atrium is trying to empty into the ventricle, the constrictive pericarditis, that is creating a knock, a sound that you hear. So remember that this will be in diastole or systole. जब blood empty हो रहा है during the ventricle filling, right? It's a diastole. So when we'll come to heart sounds, we will see that in physiology. Diastole is basically starting with what heart sound? Which heart sound we said is diastole onset? S2, right? तो S2 से diastole start होता है. S2 के बाद कौन सी heart sound आएगी? S3. फिर कौन सी आएगी? S4. Right? So early diastole, you get this S3. So basically, pericardial knock mimics your which heart sound? It mimics the S3. Right? It looks like the S3 is coming early. It's like an early S3. What is the small sign? The small sign is with inspiration, the JVP is not decreasing. जब आप इंस्पिरेशन करते हैं तो thoracic pressure क्या होता है? Intrathoracic pressure negative. It's like a suction which is created. So the blood from the vein should go into the heart. It's like a suction. The small sign is with inspiration, this is not going down. Why is it not going down? Because the pericarditis is constricting. It's not allowing the blood to come down. So remember that the small sign is also constrictive pericarditis. So constrictive pericarditis is the knock and the small. Very, very important. Like one question on pericarditis or cardiac tamponade generally is there. Okay. So yes, now this completes your medicine part, including the JVP, right? And